or MA without the use of elastics to enable the mandible in a forward growth and in a forward growth to help with the facial profile. Next, we're going into class 3 patients. I think class 3 patients, as long as you know where you're going. So class 3 is just the opposite of class 2. It will make your treatment easier to tackle. Because a lot of doctors, they think that class 3 are the most challenging malocclusions to treat. In reality, it is, because there's a lot of complications and there's issues with growth. So the retention, there might be a lot of relapse after treatment. And there's high incidence of genetics, and there's also high incidence of surgery with class 3. So usually with class 3 patients, they get referred to specialists a lot, because a lot of general practitioners, whenever they see the class 3s, they will refer, because it tends to be, challenging. However, if we are able to treatment plan and diagnose the class 3s with care, and we know how to design our ClinCheck, it will make class 3 treatment rather easy. Because with class 3, we just need to do a lot of distalization on the lower arch and a lot of expansion on the upper arch. So a good class 3 candidate is to look for upper crowdings, okay, and lower, less crowding. That will be a good case. So the most common class 3 malocclusion you will see are usually anterior crossbite, patient with anterior crossbite, and patient with anterior crossbite are usually, they usually have midline deviations. The other type of class 3 you usually see are patient with anterior open bites, even though you have anterior open bites in class 2. So after today, after you learn about the common class 2 and class 3 malocclusions, you can mix and match. Okay, sometimes class 2 they have open bite, okay, and sometimes class 2 they have deep bite. Anterior crossbite with deep bite as well. Sometimes class 3 they have anterior crossbite and together with deep bite as well. So the treatment protocols for anterior crossbites, we look at the relationship of the canine. If it's super class 1, you're looking for an AP change of around 2 to 4 millimeters. That means the lower canine has to distalize about 2 to 4 millimeters in order to correct into a class 1 canine relationship. And usually with 2 to 4 AP correction, you will just need class 3 elastics with or without IPR on the lower arch. Because the AP change is small, so you don't need extractions, or you don't need a lot of IPRs on the lower arch. However, for a half cusp class 3, that means you are looking for 4 to 6 millimeters of AP change. Sequential lower distalization is necessary to induce the 4 to 6 millimeters of distalization on the lower arch with a half cusp class 3. Anything that's full cusp is more challenging. So if you have a lower molar, mesial over upper molar in front of it, it's called a full cusp class 3. It's more challenging. The overjet is usually more than 7. Then you have to treatment plan the case with care. Those are more challenging class 3 to work with. And we need extraction or maybe surgery in order to treat the case. So let's take a look at one of a teenage case with anterior crossbites. So this is the girl that comes in, characterized with anterior crossbite, with a functional shift and mandibular deviation to the right with a midline shift. This is her before and after. Can you see the change? Okay. After the dentition, her class 3 have been corrected. She is very more confident of herself. Okay. And look at the smile. The smile is totally different. Okay. So she's characterized with the class 3, anterior crossbite, midline deviation with the lower 7 submerged, and midface deficiency and mandibular prognathism. Look at her lateral profile. Okay, it's flat over the midface, and the mandible is a bit long. E-line with the lower lips everted, and acute nasolabial angle. So by looking at her intraoral photos, we can see that she's class 1 on the right, okay, canine. Class 3 on the left, okay. Midline deviation to the left on the upper arch, and to the right on the lower arch, anterior crossbite. We have 3 clean check for her. The total treatment time is almost 3 years. The wisdom teeth is still in the bud stage. We've talked about wisdom teeth in the bud stage, you don't have to extract. However, distalization on the lower arch is more challenging than compared to the upper arch because of the difference in the bone characteristic. It's cortical bone on the lower arch and cancellous bone on the upper arch. So usually it takes longer time, and it's more challenging to do distalization on the lower arch. So we want everything to be out of our way, and we want enough space when we're doing distalization. So I want her to extract her lower 8 because, you know, her face is very prognatic. So I want it, you know, to be out of the way when she is doing her, when I'm doing, performing her distalization on the lower arch, and she's using her class 3 elastics, so that it will be effective and it will be predictable. So I asked her to extract her 3/8 and 4/8 by our oral surgeon. And on the upper arch, we plan to do upper arch expansion so that we're able to, you know, give a little fullness to the face. But without face mask, it's not that evident with just the expansion. However, if you are able to correct earlier in their teenage years, it will help with the growth on the maxilla. However, it has to be earlier, around 10. Anything later than 10, you know, the maxilla will stop growing. And lower arch segmental distalization with class 3 elastics to correct her malocclusion. So in this clean check, on the upper arch, we try to do expansion simultaneously. And then on the lower arch, we perform uni-arch, single arch segmental distalization. Because this side is class 1, this side is class 3. So we just need to distalize the lower left together with class 3 elastics only on the left to start with, because there's some midline deficiency. And we utilize sequential distalization to correct the canine into a class 3 relationship on the left buccal and to correct the midline. This is her after 7 months. Okay, the bite has opened a bit, but still in crossbite. Okay, no elastic initially. Okay, even though I planned to give her the elastics, but I asked her not to use the elastic first because I want to see how much lower distalization would happen without the elastic wear. Lower limbal segmental distalization only. Okay, look at the space that it's open. The midline is still the same because we do segmental distalization to open the space for the midline to shift to the left. Okay, look at the amount of spacing on the lower arch. Okay, so lower arch segmental distalization is very evident, as you can see from the spacing over this area. Okay, the key here is the plastic wrap on the distal border of the lower 7. As long as you have the plastic covering the distal terminal molar, it will be effective. So that the plastic wrap is able to push the canine, the molar distally, okay? And then this gap of plastic is engaged into the interproximal area. It will help with the movement or the distalization of the lower molars. So you can see it's very evident, okay? And it's compatible with ClinCheck. So lower arch distalization is also very predictable. Don't be scared with distalization. Try it yourself and see it with your eyes. And then you believe that distalization is also another very powerful protocol with Invisalign. So after 2 years, with additional aligner 1, I start for class 3 and transfers elastics. Class 3 here to correct into class 1, transfer here to correct into class 1, to correct the midline. And since this is transverse, here we pull what? A class 2, okay, because it's more class 2 here. And at the end of 2 years, she comes in an edge-to-edge position. Now, this is easier to use the elastic. When she's still in crossbite, sometimes it's hard. So once she's edge-to-edge, I ask her to hook the elastics so that you don't have to put her on elastic for a long time. With teenagers, they get lazy, after a long time of elastic wear. So we want to treatment plan and tell her the best time to use elastics. That is just as effective and that's useful for her. And not to waste too much time on elastic wear. Because usually the cooperation and compliance is much better at the initial stages of the elastic wear. After a year, they get lazy and they don't tend to wear the elastics as much as the initial stages. So elastic after positive overjet is achieved. Is the key, to elastic wear and to a compliant elastic protocol. So after almost 3 years, we were able to correct her anterior crossbite and achieve a favorable overjet and overbite relationship and her change in smile. Okay? So these smiles are, it makes us happy every day, even though we are really tired and we've engaged so much time in our patients. As you know that in Taiwan, we work until 10 at night. My clinic is closed at 10 from Monday to Friday. We have very long hours. However, luckily, I don't work the night shift, okay? Other doctors and the male doctors in my clinic, they really love to work the night shift. And they are able to help out in the clinic. But after seeing all of the smiles from all of these patients, it makes us so happy that we are able to make a difference and we are able to transform their life. Okay? I'm not really sure, but all this type of class 3, or after they have a big change in the facial, she also got into the medical school in one of the best schools in Taiwan, the Taiwan University, the medical school. And she lives not around the area of my clinic. She lives around 1.5 hour drive from my clinic. And she Googled on the internet that we are really skilled and professional in treating class 3, so she came all the way. And we did it without any extraction. Okay, no extractions, no tabs. Can you believe that? If I'm going to do her case 10 years ago, maybe I will try upper 5 and lower 4 extraction. Maybe lower 4, upper 5, upper 4, lower 4 here, okay, to correct her her treatment. As you can see, she's dramatic to start with. Can you imagine without extraction, we're able to what? To distalize the lower lip inward and change her facial profile with no extractions at all. I think that is the beauty and the power of the aligner system. And this is her. This is her ceramic, her wisdom teeth on the lower arch has been extracted at the start of the treatment. However, on the upper arch, since the path of eruption is good, I tell her to wait until it's erupted into position, and then we can ask the oral surgeon to put it out. So it's still there after the treatment. Look at her change. Look at her change. Okay, on the mid face. Okay, there's more fullness. Okay, over the angulation here. And the position of the upper and lower incisors. So what did we learn from this case? We can see that segmental distalization is also very predictable on the lower arch, as long as there is terminal molar wrap and patient compliance. If the patient is very compliant, but you don't have terminal molar wrap, it's not effective. The molar will not move distally, predictably. So you need a wrap on the distal molar. And key point number 2 is elastic together with distalization is also very powerful in correcting anterior crossbites with functional shift. And aligners decrease the severity of the malocclusion during young age. We are able to incorporate the distalization protocol to decrease the chance of extraction, decrease the chance of using complicated auxiliary like TADs, like face mask, and give or allow the patient to have a better patient journey during treatment. So that is the case for anterior crossbites. So anterior crossbites with midline deviation, you need to use the transverse elastics after the overjet becomes positive or edge to edge. That is the best time for elastic wear. Next, we're going into an open bite case. And I think some of you have seen this case as it's a very typical open bite case of mine. He is also in his teenage years with a very fish mouth appearance. Okay, he is a class 3 with severe anterior open bite with a narrow upper arch, especially on the upper left. Here too, but here it's very narrow. Okay. Transverse deficiency on the upper arch and issues with tongue thrusting. This is him before the treatment, the lateral profile. The E line, the upper arch, has more space to advance. Okay, there's some possibility to do upper advancement. Nasolabial angle is okay. Since he is in his late teens and a very severe open bite, I try to plan. So this is a class 3. So I want to close his open bite with lower arch extraction. So we plan, okay, for lower 4 extraction. And usually with open bite, it's easier with extraction because after extraction, with the space you close, the upper and lower incisor will dump. And with the dumping, you are able to close the open bite. So for open bite, it's easier with extraction. For deep bite, it's easier with non-extraction. In deep bite, if you want to do extraction, always level and align before you perform the extraction. It will make it easier. Because in deep bite, usually the curvus B on the lower arch is severe. And in severe curvus B, in order to flatten the curvus B, you need to have anchorage. And by anchorage, it means you need teeth. You need teeth to have the anchorage. So you can flatten the curvus B first, and then you do the extraction, and then you close the space. It will make deep bite easier to treat. However, with open bite, it's easier to tackle with extractions. because we can utilize the tipping of the upper and lower incisors after the space are closed and close the gap. So with open-5, there are 3 treatment protocols. You can utilize it with anterior retroclination, so that is tipping. And usually with tipping, you don't need attachments. You can just have optimized extrusive attachment, so it will come together. And that is the easiest. For a group of 4 anterior incisors, you can utilize the G4 technology. And it's very suitable in procline incisors or in patients with a lot of anterior spacing and mild crowding. The second protocol for anterior biresolution is to induce anterior pure extrusion, and that is the multi-tooth extrusive attachments, also known as the G4. Together with elastic reinforcement in patient without gummy smile. Okay? So it's good for patient with good incisal inclination and less small arc consideration. Or you can do posterior intrusion to decrease the long face or to decrease the vertical dimension on the posterior segment. And this you can treatment plan and design on your ClinCheck, intrusive force on the molars. Or you can also utilize TAPS to allow posterior molar intrusion. Very suitable in long face, dolichofacial pattern patients. So the treatment plan for this patient is to do lower premolar extraction, the 3-4 and the 4-4 extraction, and close the gap, and allow anterior extrusion and posterior intrusion to help correct the space, and together with class 3 elastics, and do some myofunctional treatment on him. So this is his ClinCheck. Okay, we did extraction, and I incorporate a little bit of distalization to help increase the anchorage preparation on the lower arch, because he's very severe. So I'm scared that with just extraction, I'm not able to get total anterior retraction. So I perform a little bit of distalization to add on to the total amount of retraction that I will require on the lower arch. So on the lower arch, I want maximum anchorage for 3-4 and 4-4 space closure. So I add a little bit of distalization to help with the anchor loss from space closure. So by distalizing, I prevent it from mesial tilting during space closure of the extraction space. So this is G4. G4 is a protocol for open bisolution. It will allow incisor extrusion on the anterior and molar intrusion activation on the posterior. It will be triggered after you select correct open bite, upper, incisor intrusion and incisor extrusion and posterior extrusion. At 8 months, the decrease of the open bite is evident, and he uses the class 3 elastics early from the start, and at the end of 2 years, we are able to bring him into a positive overjet and overbite relationship. However, there is still some gap of the extraction space, so we continue with another scan, okay? And we add a little bit of fake IPR over the extraction site, just like a digital power chain to further close the space. So this is the additional aligner. You can see here, 0.2 IPR, but I don't do that clinically. I don't perform that clinically. It's meant to be a fake IPR. You design, but you don't perform. You just want a further tightening of the plastic material so that the space can be squished together and close the gap. Especially very helpful in small spaces. And this is him after 2 years and 4 months. And we finished him at 2 years and 4 months, but I asked him to come back for follow-up, and he's rather stable. And I was very surprised. He's so young, and this was like a few years ago. And a few months back, after Chinese New Year, he brought his daughter, okay, to my clinic, and he wanted to show me. He married at a very young age, around 24, and he brought his wife to for Invisalign treatment as well. His wife is class 2, very severe class 2. You know, class 3 tend to marry class 2. I have a lot of couples that are this way. So it will make the treatment a lot easy for the patient, because the patient doesn't have to undergo a lot of like surgery, a lot of extraction, a lot of tags, and we are able to control his anterior retraction with less tipping and with a lot of good maximum anchor preparation. And this is his mouth before and after the treatment. And his lateral profile, the upper lip is fuller, okay? And the panoramic, the open bite, the gap, closed. This is his cephalometric, the facial changes. And if you are interested, you can go to the gallery under 1004. You can check out his clean check again and study his case. I have a few treatments approved on the gallery. If you are interested, just type my last name, CHIU, and you're able to see them all on the gallery. Most of my cases are black cases. That means more challenging, because I'm an orthodontist that does a lot of challenging cases. I don't have like light cases. I seldom do light, because most of my cases need about a year to finish. So the key learnings here are G4 protocols are very powerful for class 3 anterior open bite correction. And midline correction is also very predictable with aligners together with elastic. It's the best match. With midline deviation, the earlier you put on the elastics, the better the treatment. So you move everything, to the other side as fast as possible. And you stop after the midline is coincident with each other. And dental compensation is rather evident in class 3, so lower incisors are a bit lingual tipping. So with class 3s, on the lower incisors, we will add a lot of lingual retort to prevent the lower incisors from too lingually tipped. Because with too lingually tipped incisors, there's a higher incidence of gingival recession. So everything is here. Is where we start in the day. Okay, this is the cheat sheet. Okay, so when we diagnose and treatment plan, we want to differentiate or troubleshoot in different planes of malocclusion. Okay, so sagittally, class 1, class 2, or class 3, how they do. Okay, the final position, this is the treatment goal. And what you should do on the tooth movement plan. If you forgot and you slept through the lecture, don't forget this chart. This is the cheat sheet. So when you're doing a clean check, always remember for class 2, you should do upper retraction and lower advancement. And here are the tooth movement planning that you can do. And vertically, we refer to the deep bite and open bite, transverse, narrow arch, or cross bites. So just to sum up for the treatment on team treatments, on some of the treatment goals, and what are some of the tooth movements you are able to design and manipulate for your patient. So before we end the day, I just want to take a few minutes to share a little bit about my practice. As I've shared, my practice starts from 9 in the morning and ends at 10. However, I don't work from 9 to 10. And I don't work every day. I was accredited in 2009, but I started slow. As you know that before 2014, the Invisalign material is not SmartTrack. It's a more rigid material in which is not that comfy, it's not that predictable. There's no button cutouts, there's no power reach. We have to cut the button cutout ourselves. There's no chewies, there's no aligner plier. You cannot even imagine. Okay, there was once a time that we do our own chewing. We cut the suction tube and ask the patient to bite on those suction tubes. We have to pull the brass wire out and the patient bite on the suction tubes. And then there's a time that we have to buy chewies on Amazon. And now a lot of distributors are providing chewies, different types of chewies. There's the round type, the flat type, the munchie, everything. It started to grow after the material of Invisalign was transformed into the SmartTrack, because it's a softer material, more flexible, more patient, is more adaptable to this new material, and we are more experienced. And there's more doctors using the system. There's more doctors that is there to share their experiences for me to learn, and it started to grow. But I think the first change that I encountered is with the utilization of my first scanner in the clinic. And since I don't work every day, and since before 2017, there's no iTero yet, we got the first intraoral scanner in our clinic. There's a bit of growth in our cases. However, at the end of 2017, we had our first iTero scanners. And can you see, with the same working days, the same staff, we're able to increase by more than 100%. But unfortunately, COVID hits, okay, and our numbers drop. I'm very honest. I just put it from my account and share it with all of you. But after COVID, at the end of 2021, we adopted the newest version of the iTero scanner at that time. And in just 1 month, this is like 6 minutes, okay? This is 2 minutes. My staff have to finish the scan in 4 minutes, but they usually finish it in 6 minutes. And with the new scanner, the requirement for my staff to do the scan is they have to finish it in 4 minutes. And now they're able to do it within 2 minutes after some skills. And we're able to get 50 patients in a month, okay? So I'm not the one who chooses the scanner nowadays in my clinic. It's my staff, they say it's good, it's gonna help them, and I'll make the decision to adopt. So the system is not only a liner plastic. You have to adopt a lot of new technology to help your practice grow. And that is my story, and I hope all of you will love the iTero system because it's going to change. Not only the Align Oral Health Suite that Dr. Barra has shared earlier in the morning with all those functions and all those information and evidence and all those photos and all those models and the before and after, or the occlusion, or even the MIRI to check the caries, interproximal caries. What's more is we are able to show and communicate with some visual aids, and we are able to print out an iTero scan report for the patient to bring home. Because if they have something in hand, they're able to take it out and then re-evaluate what you have to tell them and see for themselves how their teeth is and what is wrong with their teeth. Because a lot of patients, they don't understand what is their own problems. But with all these photos, even though this is Chinese, but we have our report. This one we just print it out, okay? And I just tick, okay, what you need in this line, X-ray, and then whitening, okay, and what are her issues of the dentition. You can just, tick, and then this one you can print it out for her. So every consultation, before the patient goes home, we have a digital copy, sent through their line, and then a hard copy for them to bring home. Not only digital, because digital is very small. It's hard to see the big picture. And if they have the hard copy, they're more able to show to their friends, and they are more able to see that, oh, this is the thing that they need to decide whether to go into treatment or not. And then we have a lot of instruction forms that are very playful and colorful, just like the teen theme. It's pink, but it's pure orange. But everything is pink for me. I have a lot of pink slides, and even my name card is pink. My uniform is pink. Everything is pink for me, okay? Even my instruction forms. And we have a lot like how you use the chewies and how you wear your Vivera and everything, okay? So, before utilizing Invisalign in my treatment, in my practice, I don't treat a lot of teens. But now, I treat a lot of teens, and not only teens, okay? I'm able to go even further, earlier, in early mixed dentition, in treating kids in their 6th or 7th, with only the 2 to 2 erected, with the first package. And with the first package, there's also a lot of things to learn. The first package, we have to do a lot with arch expansion, arch development, and a lot of space planning. And with the Align system, there's a lot of product line that's going to help you and help us provide better treatment that is more predictable, that is safe, that is comfy, and that gives better patient experience for our patients, and it will help our clinic grow as well in the long run. Because going digital is the key of the orthodontics or the dentistry nowadays. So if you're curious of how many days I work and how come I can come to Vietnam for 4 days in a row, and I have 3 kids, okay? I work 2.5 days a week. I work every Tuesday morning, Friday morning and afternoon, and every other Saturday. I don't work the night because I have 3 kids, and my kids are still young. One is 6, one is 12, and the other is 13, and they need my time. However, with this time of working hours, I'm still to keep a competent digital workflow clinic working. And I think it's not only Invisalign, it's because my team, with Invisalign, we're able to boost teamwork and induce better productivity and better relationship between the staff and us. And we, in the long run, it's a better working environment for them. So, to wrap up for the day, thank you for having me here for the session on team treatment. I hope you have a lot to take away, and I hope you have a lot of information, and you are able to incorporate into your practice and to allow and to treat more team treatments in the coming summer months. As I heard from Dr. Ha'an, that the summer vacation is 3 months here. So I think that's a lot of opportunities. As in Taiwan, we only have 2 months, okay? So we need to market early. Even in our clinic, we market like at the end of June. And we're only going to get the patient only at the start and at the end. In the middle, all the kids are flying, somewhere around the world. So I hope that you have a lot to take home, and I urge that with the Align system, we're able to transform the smiles of our team. So let us embark on this transformative journey together, shaping not only their team, but also their life, and changing their lives and smiles. Thank you again for having me here. And then we have another interesting section on live scanning with the Lumina. So we'll welcome Dr. Perron on the stage, and then he will show his magic on how fast he can do the scanning with the Lumina. So everything is about speed. Okay? With speed, we're able to save a lot of clinic time. Thank you.